Good afternoon, everyone. Thank you so much for the opportunity to speak today. I'm actually really excited that I was preceded by Dr. Siebert, who just gave us a really great sort of change from the morning schedule in that we're really trying to think now about prevention and less about, if someone has a disease, how do we treat that? And I think that's what this afternoon session is really going to focus on. So what I'm here today to do is to really make a case for population screening for BRCA, Lynch syndrome, and familial hypercholesterolemia. And for those of you who don't know what those are, I'm going to go through that in more detail. But what I wanted to do first is tell you a little bit about Color. I don't know that a lot of people have heard of us, so I wanted to give you a little bit of background. I know that our CEO, Alad, and co-founder, Alad Gill, actually spoke at this conference 2 years ago, so this audience is probably a little bit more familiar with us than most. So Color, our mission is to democratize access to genetic testing and to do this in a responsible way. And what that really means is that we do have an NGS-based genetic test for BRCA mutations along with 30 other genes that are associated with hereditary cancer. All of our tests are physician-ordered, and we are doing full sequencing. We have complementary genetic counseling that's included with every single test, and that's part of making sure that we're doing this in a responsible manner. And we do contribute back to research, and that's actually what my entire department is in charge of, is working with academics to try to use the data that we've collected from all of these different patients and do something good for the field. What's really differentiating about us and what makes us very accessible is our price point. So we're available at $249 for a 30-gene test. We have a BRCA1 and 2 only test for $99, which makes us the lowest cost test for germline testing for BRCA mutations on the market. We make informative and actionable reports, and the reason we do this is because we have a very unique delivery model where we actually do have a direct relationship with the end patient. That patient receives their report at the same time as their physician, and that report has on it very clear language around what does it mean to carry a mutation, that this is a risk, this is not a diagnosis, and that there are actionable screening guidelines that can be followed to prevent disease. And so we really want to make sure that the patient feels that they have been given the tools to understand what their genetics means, what having a mutation might mean, and how they can prevent disease in the future. So these are the two diagnostic panels that we currently offer. The top one is our hereditary cancer panel. It has 30 genes, including BRCA1 and 2. The bottom is familial hypercholesterolemia. This is inherited high cholesterol and is associated with cardiac disease and heart attacks in many individuals. What I really want to talk to you today about is not these two diagnostic panels. What I actually really want to talk to you today about is population health. And so these are the genes that you would sequence in somebody that you know is of high risk. Usually you're looking at people with very indicative family histories that make you think there must be something genetic in their family that's causing that disease. And so then you would do a large panel to try to figure out, do you carry a mutation that is increasing your risk of you and your family for these cancers? One of the things we've been thinking actually very hard about is what Dr. Siebert just told us about, which is polygenic risk scores as well. There's also these polygenic genetic components that are potentially increasing your individual risk for cancer. Those are harder to track, they're harder to understand from a family history standpoint because of the fact that they're polygenic, but they're still germline. So these are all things that we think about in the diagnostic testing space. Just some quick tech specs. We do accept both saliva and blood, and actually for the purposes of research, we also accept extracted DNA, so we do a lot of biobanks where we're actually going back on frozen samples that were banked. We do full sequencing of all the coding regions of all the genes that we cover, and we do all variant types, including large rearrangements. There's always orthogonal conformations done at every step, meaning that if we find a single nucleotide variant, we're going to do Sanger sequencing to confirm that. Large structural variants we confirm by other orthogonal technologies like ArrayCGH or MLPA, depending on what type of variant it is. And then we do follow the ACMG guidelines for variant classification to make sure that we try to align as much as possible with the recommended guidelines on how to classify and call these variants. What's really interesting is we have 4 unique channels for client acquisition, and this is something that a lot of people don't really know about us. So the First one is the organic channel, the online organic channel, and this is the one that most people are familiar with us. You can find us on the internet. You might see an ad for us in Facebook or on TV, and you come to color.com and you purchase your kit. We have a lot of people who come to Color that way. We also have a clinical channel, and this is your standard genetic testing channel where we're working with genetic counselors, oncologists, primary care providers. They order our testing for their patients. What's very unique is we have the enterprise channel, and the enterprise channel is what I would really consider a true population genomics channel. And the reason is because what we're doing here is we're working with large employers to offer genetic testing into their population as a benefit for working at that company. So it's kind of like you get your health benefits, your vision and your dental, maybe you get a free gym membership. In many cases, our partners, they offer a free genetic test as part of that, completely voluntary, but a lot of people actually do take it. And the last channel is the one that I work mostly on, and this is our research channel. Research channel, we really work with all of our academic collaborators to figure out how do we bring genetic testing to a study to make it so that you can start to give germline, actionable information back to every participant in that study. Giving research return of results when you're doing whole exome or whole genome sequencing so that all of your participants are partners in your study and are getting something back rather than just being participants. How it works is that we take a saliva sample for the most part, and this is part of what makes it very accessible, is that we can mail that saliva sample to your home through the United Postal Service. We're actually also available in 150 countries, so we also mail saliva kits abroad. The results are actually delivered to you online through our portal, and then you can have counseling with one of our Color board-certified genetic counselors, where then you're able to get your results back. And then we make it very, very easy for you to share those results. It's important that you share those results not only with your healthcare provider, but also with your family, especially if there's a no mutation in your family. It's important for them to get tested as well. So that was a little bit about Color, and what I really want to talk to you today about is population screening. When we think about population screening, we're really thinking about prevention. We're really thinking about what is something that we can do for every single person so that we can prevent disease in the future. A lot of common population screening that we think about is going to your annual physical, getting a mammogram if you're a woman, getting your PSA screening if you're a man. These are all things that a lot of people do. It's recommended to do, but no one has really thought about genetic testing for the purposes of population screening. From my standpoint, I think there's really 6 criteria that you need to meet in order to do population screening. The first one is that it has to be actionable. Second is that it needs to be cost effective. 3 and 4 kind of together, you need to be able to get people to actually do it. It's one thing to say that it's effective, it's one thing to say that it's going to work and the science backs that. It's another thing to get people to actually do it. And the only way you can get people to actually do something is to make it really, really easy. For the purposes of population screening for a genetic condition, one of the huge bottlenecks is genetic counseling. There are not enough genetic counselors in training right now or currently practicing to actually deliver all the counseling that we need for the people who are going to have mutations and therefore need genetic counseling. So there needs to be a shift in the paradigm in the way we think about genetic counseling to make sure that we can serve all the individuals that might need it. And then the last piece for a genetic condition is cascade screening. So this is once you've identified a person of high risk and that has a mutation, all of their first-degree family members are now at 50% risk of carrying that same mutation. There is no higher risk population than those first-degree family members. So how do you get all of them to take that test? So looking at actionable screening, the CDC recommends these Tier 1 genomics conditions. These are the ones that are really have been studied the longest, and the penetrance and prevalence of them in the general population is the most well understood. And so that's why these are the 3 conditions that I'm trying to make a case for today. Those are BRCA, hereditary breast and ovarian cancer, so BRCA1 and 2, Lynch syndrome, which is a form of hereditary colon cancer. There are 5 genes associated with that. And familial hypercholesterolemia, which is inherited high cholesterol. And there are 3 genes associated with that. What's very interesting is that the Geisinger-Mycode study recently has published some of their findings that show the prevalence of these 3 conditions in the general population is actually quite a bit higher than what we had previously thought. In fact, what we previously thought was that the prevalence of these mutations was going to be about 1 in 150 in the population. From the Geisinger-Mycode study, you can see it was actually half that. About 1 in 80 individuals in the general population carries a mutation in one of these 3 conditions. What's important is that they're actionable, meaning that once you know that you're at elevated risk, there is something that you can do to prevent that risk. And so obviously, very famously, Angelina Jolie has taken actions for having a BRCA1 mutation. She had a prophylactic mastectomy, and after finishing childbirth, she had an oophorectomy. If you have an FH mutation, there are drugs that you can get on to lower your statins to make your heart more healthy. So it's important that if you know that you're at higher risk, you want to know at a point where intervention is still possible. Unfortunately, right now, most individuals don't know about their BRCA mutation until after they have cancer or after they've had multiple cancers. How do we shift it so that now people can have access to that at a point when they can do something that's preventative? The next thing is cost effectiveness. So cost effectiveness is something that really obviously depends on how much something costs. And so this was a JAMA Oncology article that came out in 2015. It actually was published just a few months after we launched, and we had nothing to do with the publishing of this article at all. But it looked at what is the cost effectiveness of universal screening for BRCA1 and 2, and just BRCA1 and 2. At the time, Color was about 3 months young, but they actually pointed us out in their analysis, saying that if the price of BRCA testing could fall to $250, which was our market price, that the cost per quality was $53,000, and that was cost effective compared to here, you can see annual mammography, and here, for the general population, had a quality of $350,000 per quality. And so this is only 2 of the genes that I'm talking about. You can imagine that as you add in Lynch syndrome and FH, which are going to increase the number of people who are affected and whose lives are going to be changed, the cost effectiveness actually becomes almost a no-brainer. Obviously, I know you all are scientists and you want that to be backed by data, so that is something we're actually working on right now, where we're planning to publish within the next month, is the cost effectiveness of doing these 10 genes in the general population. Broad-based patient recruitment and engagement. This is kind of the magic sauce of consumer genetics. What we've come to learn about giving people access to genetic information is that people actually really want it. People are curious about their genetics, not just from a traits and ancestry standpoint, but people are curious about their health. And so how do you make recruitment successful? We found there are a couple of things that work really well. One is doing on-site education and sample collection. Digital marketing and outreach with some kind of emailing or email blast to a group is very helpful. But then the last piece is to make a very simple online enrollment. You don't want to make it hard for people to sign up. And so what I want to do is take you through a case study. So I mentioned to you that we work with many different enterprises. These are just a few of the ones that we work with. And most of these companies are offering the color test into their population at subsidized or no cost. What I'm taking you through today is a case study that we did with SAP, which is a company that is based out of the Bay Area, just like we are. And we worked with them to introduce color testing to their population. This was the plan that we took with them. So as I mentioned, in order to make engagement possible, you have to plan from the get-go. So pre-launch, we worked with their HR team to make sure that we had a good comms plan and that their HR team was on board with understanding what was the program that was being offered. At launch, we did a digital outreach with email newsletter and a webinar, as well as social media, to make a push for people to understand that there is an event that's coming up where they're going to get access to a genetic test, that they should come and talk to one of the genetic counselors and learn about what are the risks, benefits, and limitations of genetic testing. And then, of course, there was the physical on-site education where we actually had genetic counselors and support staff from Color go on-site to be able to bring our saliva kits on-site so that people could take the test if they wanted it. The ongoing engagement piece is really important. Once somebody has taken the test, once they've gotten their results, you don't want them to sit on that information and not do anything about it. So it's important for them to understand that there is an ongoing component. If you know that you're at increased risk, that you need to be complying with your increased screening measures. If you're at average risk, and you got a negative result, there is still annual screening that you should be doing. You should still go to your physicals. You should still be following guidelines for mammography. It's important that you continue to engage, and to do that, you have health fairs, but also one of the things that we do is that we reach back out to patients and let them know and remind them that they have a screening coming up, that they should be looking into scheduling their next mammogram, et cetera. The last thing is making our enterprise partner feel that they're really a partner with us by giving back the data to them in a de-identified and aggregate manner so they really understand what is happening in their population, how to improve the health of their population. So as I mentioned, we did an on-site recruitment. Here's just some pictures of that. So we brought our genetic counselors and support staff down to the SAP headquarters and did our on-site recruitment. We also had custom digital marketing that we put together for them, as well as print marketing that we put together for them so that they could distribute that on-site. And we created a custom portal. So the way that this works is that any SAP employee could come into this website that we created for them. As long as they had an SAP email address, they would be whitelisted to have access to this program. Once they've signed up, they could change that email address to their personal address if they didn't want to attach their work email to their results, but just using that SAP email address gives them access to the program. We found that in the first week, more than 800 people actually participated, and they came to our on-site or signed up for the kit online without even coming to the on-site. We got a lot of social media buzz around it. People were very excited for the idea of doing it. And what we actually found is that we were able to reach a lot of people. Within the first 3 months of launching the program, we had over 20% participation from the eligible members in the SAP community. About half of them were female, and half of them are male. To us, this is a huge success. Most men do not think about prevention. I think most of you guys know that. And so to be able to get half of the participants be men is actually a huge milestone for us. The average age was 43, meaning hopefully most of these people were still unaffected and were at an age where doing something preventative was going to be helpful. And 35% were non-Caucasian. As you know, most genetic testing studies that have been done to date have been done mostly in Caucasian European descent. It's important for us to start sequencing and testing individuals who are non-Caucasian. That is the only way that we're going to start to understand how to do prevention better in non-Caucasian populations. The most important thing is we identified 29 new carriers of BRCA1 and 2 and Lynch syndrome. In this iteration of this study, we did not do FH, so that's why it's not here. This is the funnel. So you can see we looked at about 3,000 people who took the test, and in total we found 29 carriers. The prevalence of these diseases that we found in this population very much echoes what the MyCode data has shown. So you can see this is what MyCode has. This was the data from our study. These conditions are much more prevalent in the population than what previously has been published. And the reason is because to date, all of those publications have been done in affected individuals, and we've never really truly understood what is the population frequency of these diseases. And the only way to do that is to sequence the population. All of the people who got a result talked to a genetic counselor, developed a personal risk plan with that genetic counselor, and shared that information back to their healthcare provider to make sure that they had a customized risk management plan going forward. And of course, it was received very well, and we had a lot of people on social media saying they really enjoyed having this as a benefit and that they liked working for a company that felt like they really cared. The last two things I want to talk to you about: genetic counseling and cascade testing. I apologize. I also have the cold that everybody has. Yeah, you're really going to have to sanitize this mic at the end of this. So what's our approach to genetic counseling? We have board-certified and licensed genetic counselors in all 50 states, and we do all of our scheduling done online by the patient. The counseling is delivered over the phone, and it is required for anybody who has a positive result. It is optional for anyone who has a negative result. We want to be able to do genetic counseling at scale, and the only way to do that is to decrease the amount of time it takes to do counseling. And so you can see here we looked at a bunch of previously published studies for how long it usually takes a genetic counselor to counsel one new patient. A lot of the time gets spent on indirect care, and what that really means is drawing a pedigree, getting that family history, running the risk profile, getting the file in place before the patient comes in so that you know what you're going to talk to them about. A lot of this is done very manually right now in the clinic. We need to automate those things. And so at Color, what we've done is generated a lot of custom software to do that. We have our own pedigree generation tool. We have our own risk profile models that are run automatically. So Gale and Klaus models are run automatically on people's family histories. And then we let the patients do the scheduling rather than having to make the clinic do the scheduling. And that actually saves quite a lot of time. The uptake of counseling, as I mentioned, for all positive individuals, you must have a genetic counseling session in order to get your results back. You can see that we have almost 100% uptake with a very small error bar. Negative patients still use the genetic counseling, but not nearly to the same extent. Most of the people who take the genetic counseling with a negative result are because they have some kind of indicative family history that we want to still talk to them about. And so you can see that this is one way you can make counseling more efficient. Our missed appointment rate was 3%. The industry standard is about 12%. And so we think the reason that we're able to get our no-show appointments down so low is because, again, the patients scheduled it themselves, so they picked a time window that they were available, and it's by the phone, so they don't necessarily have to take a half a day off to go into a clinic in order to see a genetic counselor, so they're more likely to keep that appointment. The average counseling appointment takes about 45 minutes for a positive, a little bit less time if you have a VUS result, and a little bit less time if you have a negative result. In the end, the things that you discuss with somebody are kind of the same, regardless of whether you have a positive or negative result, and so it's not that surprising that the average counseling appointment, for the most part, is really in the same range, about 30 to 40 minutes. The last thing I want to talk to you about is cascade screening. This is something we really wanted to tackle because, again, these are individuals who are at 50% risk of carrying a mutation. There is no higher risk population out there for a mutation than these people. And so what we did is we created the family testing program. We offer $50 testing. That's a full panel test for any first-degree relative of somebody who carries a mutation. That original test report doesn't have to be from Color. It can be from any CLIA-certified laboratory. So if they got a Myriad test, an Invitae test, they just upload it in, and then we will test the first-degree relatives. The kit is shipped to the patient's home, and the counseling is delivered by Color. This feels trivial, but it's actually very important, because right now in our modern day and age, the woman who has a BRCA mutation in California, her sister lives in Philadelphia, and that genetic counselor in California can't actually reach that sister in Philadelphia. And so that's a lot of the reason why cascade screening doesn't happen, is because it's inconvenient, or because the healthcare provider feels like they can't take that person on as a patient because they don't live in my state or live in my area. And so by taking this on, we have actually lowered a lot of the barriers for cascade testing. This is a publication that we're putting together that we just recently submitted that we're co-publishing with Dr. Allison Curian at Stanford. This is looking at the first year of our family testing program and what the results of that. What we found is there were about 1,000 people that applied to the family testing program. 750 of those people were actual probans who carried a mutation. About 360 of those people were first-degree relatives of the proband. Most of these cases were ones where the proband is deceased, and now the first-degree relative is applying on behalf of their deceased relative. You can see that in most cases, the invitation rate was about 3 to 1. So for every person who had a mutation, they invited 3 of their relatives. And we found that the overall uptake in our program was about 50%. How does that compare against industry standard? The problem is there isn't a good industry standard for hereditary cancer. In the FH field, we know that you can get cascade screening testing uptake even higher. Our colleagues in the Netherlands have done an amazing job to eradicate FH out of the Dutch population. The way they do that is they put phlebotomists on bicycles and send them to people's homes and get samples from first-degree relatives. So short of doing that, because we can't put everybody on a bicycle in the United States and bike across the United States, how do we make it easy for people to have access? That's something that we're still trying to solve. The uptake of testing was definitely higher in females than males, and this is not something that was very surprising either. You can see that across all 3 generations, depending on whether it was the mother, the sister, or the daughter, they had higher uptake than the fathers, the brothers, and the sons, even though they were equally invited into the program. Again, this is because often with men, prevention is not something that is at the forefront of their mind. Men tend to take action when there is something actionable in front of them. Men tend not to care as much when it's something about prevention. But what can we do to activate that in men to understand that they should do something? And really, how do we tailor the message so that everyone really understands the importance of it and takes this testing? These are all open questions that after this first year of the program, we're still trying to answer, but we have some preliminary data now to benchmark against to know then how can we get better at this. So at the end of it all, what I've hopefully laid out to you today is really how do you do population screening for these 3 conditions? What I really want you to think about is how can we do this by bootstrapping our way to population health? And so obviously the way that everybody thinks about it is you get the payers to do it, so you got big insurance payers to pay for this. Problem is that takes a very, very long time and is very, very inefficient. So in the meantime, we've shown that you can do it with self-insured employers. I showed you our SAP case study. The other way you could do it is working with integrated health systems where you have a payer and the provider in the same system. Another really interesting way is to have the patient initiate this movement. And that's something that consumer genetics allows us to do, where somebody now actually pays for the testing themselves, gets the information for themselves, and feels that they are owning their own health. This is one way to do it from a bottoms-up approach so that everybody who wants population health can get it for themselves. And the only way to make that happen is to make it easy and affordable. The last way that I want you all to think about is doing research return of results. We talked here a lot today about sequencing patients for trials and using that data to understand their prevention and their treatment, sequencing their tumors, sequencing their blood, sequencing everything. If you could return results on that sequencing back to them for these 3 conditions, we can bootstrap our way to population health. So that's the last thought that I want to leave you all with here today.